Hello, my friends, and welcome back to Penny for Your Shots, Conversations and Cocktails with Brilliant Women. Today's conversation is one I've been so excited to share with you because we're talking about something that affects so many of us. And for far too long, we just haven't talked about it enough. Peri-menopause, post-menopause, hormones, urinary health, sexual health, and what it means when we hit that phase of life where we just don't feel quite like ourselves. My guest today is Sarah Norris, a nurse practitioner in urology and a Menopause Society Certified Practitioner. She also happens to be my urology provider, so I can tell you from personal experience that she has helped me understand my own body in ways I wish I had known years ago. And before we jump in, just a quick note. This conversation is meant to be educational and encouraging, but it's not personal medical advice. Sarah and I are sharing information to help you ask better questions and to have better conversations with your own healthcare provider about your body, your symptoms, and what might be right for you. What I love about this conversation is that Sarah takes topics that can feel awkward or intimidating and makes them feel normal, understandable, and kind of empowering. If you've ever thought, what's going on? Is this just part of aging? Am I stressed out? Is something wrong with me? I hope this conversation reminds you that you are not alone. You're not broken, and it's absolutely okay to ask questions and to advocate for yourself. So pour yourself whatever feels good today and join me for this important conversation. Here is Sarah Norris. I think it's going to help a lot of people because this is just a topic that we don't talk about or we haven't been talking about enough.
Yeah, we really haven't. And the more and more that I'm hearing is girlfriends getting together and actually starting to talk about like what's going on in
Yep.
their life, right? Whether it's like
Yeah.
symptoms they're having or like issues with relationships and just kind of realizing like, hey, we are kind of all experiencing a lot of the same stuff,
Yeah.
you know?
It's
So,
helpful to know you're not alone.
yes, absolutely. It
Yeah.
takes a village, right? To get through
Absolutely.
menopause and get through menopause
Oh,
and raise a family.
for sure, for sure. Well, let's back up a second. And for my audience, tell us a little bit about you. Give us your name and a little bit about what you do.
Yeah. So I'm Sarah Norris. I'm a nurse practitioner. I work in urology. I specialize in a few different things within the urologic realm. So one of my most recent kind of passion projects has been menopause hormone therapy. But what kind of led me there was when I started in urology, I would see a lot of women coming in with complaints of urinary symptoms, right? So, urgency, frequency, recurrent urinary tract infections, and realizing very quickly that, well, we prescribe vaginal estrogen to help with a lot of these symptoms. And then seeing how well it worked. And I'm like, well, why does it work so well, right? Why does
Mm-hmm.
vaginal estrogen, a cream that we put in the vagina, why does it work so well to actually improve not only like skin integrity, but urinary symptoms, right? Like leakage, having to go to the bathroom several times a night, recurrent urinary tract infections. I mean, that's a bother that a lot of women have and can end up in the hospital. So it led me down kind of a rabbit hole of discovering what hormones can do for the body in general. In urology, it was very common for us to see men to replace their testosterone, right? And
Uh-huh.
also to manage sexual function in men. And it just kind of got me thinking too, like, who's doing this for the women? Because
Right.
I know as a woman myself going to the gynecologist, they don't ask, I've never been asked about sex before, or, if I'm
Mm-hmm.
having other like female sexual symptoms or other symptoms just related to hormones in general. So it kind of just led me down a rabbit hole, started doing
Mm.
some research, and I'm like, more women need to know this, that this is, help is here. It's been around for decades. These are natural hormones that we can provide to women and can really improve quality of life.
I did a little bit of digging before our chat today,
Yeah.
and I was curious about women's health in general.
Mm-hmm.
And I knew it was recent, but it infuriates me to find out that it was 1993 when it became mandated to study women's bodies and the effects of some of the drugs that are out there and just
Mm-hmm.
in general. that
Yeah.
1993.
Yeah. I mean, that's insane. It's to think about how long, there have been studies on new medications and treatments that are coming out and to not include women until
Yeah.
just recently. I mean, really, that
Yeah.
is like just recently. It
For
seems
sure.
bizarre. We
Well,
look at what I think is interesting too is so on that point, think of how many women are prescribed statin drugs when their
mhm.
cholesterol levels start to rise
Mhm.
post-menopause, right? And we see that all the
Right.
time. Statin drugs were never studied in women either.
Mm,
But we
right.
do know that estrogen, when replaced in women or maintained at good, adequate levels in women, can actually decrease cholesterol levels, right?
Mhm.
And just as effectively as statin drugs. So it's interesting that we've known that statins were never studied in women, but yet here we are prescribing them to most
Yeah.
women with cholesterol problems.
Yeah, we're not just little men.
Correct.
It's just
Yeah.
annoying. The
Yeah.
other thing I saw too that was, oh my God, so stupid is menopause is still um, an elective.
Hmm.
It's not taught in medical school unless it's an elective. You can grab it if you want it, if
Yeah.
you want to learn about it. But how is that possible? I mean, so I think you said to me half of the population roughly is
Hmm.
women, and
Hmm.
100% of us will go through
Hmm.
it.
Yeah.
And it's an elective? How's
Yeah.
that possible?
And, just from what I've heard too, I mean, I know from my education in nursing school and then in NP school, I didn't have any set courses on menopause in general, or really what happens to the body or to women's health in menopause. We learned you quit having periods, you can't have babies any longer, and you might have some hot flashes, right? Like essentially, that's what we
You
learned.
might.
Yeah,
Yeah.
you might, yeah. And so which again, when you actually start to study what hormones do in women,
Hmm.
it's astounding. And I think what is most frustrating about it is that we know, so for decades, estrogen alone, which is, one of our dominant hormones, um, is actually FDA approved to prevent osteoporosis, right? Like that
Mm.
is one single FDA approved reason to start a woman on estrogen therapy. And how many women develop osteoporosis? Like
A
most of
lot.
us, right? And
Hmm.
so that's frustrating to me in its own is that primary care docs aren't educated on that. I mean, we could start women on estrogen and decrease their risk of fracture, right? Ending up in the
Hmm.
hospital with a hip fracture when they're 70. And then we fracture a hip. Most of us don't return home independently either. So,
Hmm.
um, a lot of scary statistics behind that as well.
Wow. Tell me a little bit about the study that came out
Mhm.
that scared everyone away from taking hormones, the hormone replacement therapy. What's the deal with that?
Yeah, so I mean, the Women's Health Initiative study is what most people think of when they think, well, estrogen causes stroke or breast cancer, right? And
Hmm.
so, even though that study did, it was some of the data was misrepresented. We actually got a lot of very good data from it as well. So it shouldn't be, put down completely. But the data that they got on the breast cancer, for instance, basically we had two groups of women. So, one group of women was prescribed hormone therapy, and these were
Hmm.
different hormones than what we prescribe now, right? These were synthetic hormones that, again, have some great safety data behind it, but synthetic hormones, both the estrogen and the progesterone. And then
Hmm.
we had a group of women that were not on hormones. In the group of women on hormone therapy, 5 out of 1,000 developed breast cancer. In the group not on hormone therapy, 4 out of 1,000 developed breast cancer.
Oh my.
When they compared the numbers and they said, well, 4 versus 5, they looked at that as like some 20% increase in breast cancer risk.
Oh
When
my
really, if
God.
you were to tell any woman it was the difference of like one person out of
Uh-huh.
thousands of women, most of us could decide for ourselves, like that is not statistically significant, which it really isn't. Um,
Right.
and what they really found out that it was more so the women that were taking the synthetic progesterone
Mm.
in that group that developed the breast cancer. So really doesn't pertain to the estrogen at all. In other studies, they found that women that start hormone therapy, specifically estrogen, within that 10-year window of your last menstrual cycle or natural age of menopause, that there's actually a decreased risk of breast cancer. So
Mm.
it can be very breast protective, right? So
Mm-hmm.
something, that they also did not tell us about. In that same study, they were really trying to research the effects of hormones on cardiovascular health. They were looking at, can estrogen decrease cardiovascular disease risk or even improve cardiovascular function? The problem is a lot of these women were well past the age of menopause, and they did that on
Mm.
purpose because they knew that if they gave a woman in her early 50s, late 40s estrogen, she would know she was in, the control group because, oh, I'm not having hot flashes, I'm not having night sweats anymore, so I know I
Okay.
must be getting the estrogen, right? So they picked women that were like a median age of like 65, right? So
Okay.
anywhere from like 63 to even like early 70s were
Mm-hmm.
the ages of these women. And so a lot of them already had other comorbidities. So that in itself, when we're looking at
Mm-hmm.
starting hormone therapy in women, we look at all of the comorbidities that they have, and women that already have some degree of heart disease, right? It's a little
Mm-hmm.
riskier to start hormones. So just the whole study and how they looked at the data that they got was really just misrepresented.
Mm-hmm.
We did still find, though, that it can in the younger women, and this has been in studies following the WHI, that hormone therapy, particularly estrogen, if started within that 10-year window from last menstrual cycle or natural age of menopause, that estrogen is cardioprotective and it can decrease
Mm.
one's risk of heart disease by 30 to 40%, right? So
Wow.
that is huge. That is
Mm-hmm.
also something that I wish every woman knew so that they could make their own decision on whether or not to start hormone therapy.
Exactly. Yeah, just having the information so that you can make an
Mhm.
informed choice rather than just trusting, one
Yeah.
piece of information.
One piece of information, or a lot of times it's like the women aren't reading this study, right? They're
Right.
talking to their friends and,
Yeah. Or they're going
other.
to the internet.
Yes, and like, is hormone therapy safe? And then, like, the first thing that will pop up is, oh, hormone therapy has been found to increase like stroke risk and breast cancer. And it's like, you've just got to be careful where you get your information.
Right, right. Well, and so much of that information was from that one study
Mm-hmm.
many years ago that
Mm-hmm.
has been debunked.
Yes.
But it's still out there. It's like anything on the internet. It is just there. It's
Yeah.
forever.
It's true. I mean, in one kind of great landmark that we've made recently was the FDA has actually now removed of the black box warning labels
Yeah.
on estrogen products, right? So
Yeah.
estrogen products across the board. Sure, we know that like oral estradiol, even in bioidentical form, the oral estradiol can still increase one's risk of a blood clot very, very, very slightly, right? But in speaking of that, saying that estrogen causes stroke or dementia or breast cancer is truthfully just wrong, incorrect.
Mm-hmm.
And so I know doctors have been trying to get that black box warning removed for a long, long time. It's finally
Mm-hmm.
happened, which is great, and I think will really help decrease that fear, amongst
Yeah.
women interested in taking hormones.
Yeah, that's great. Well,
Yeah.
can you tell us a little bit about taking progesterone with estradiol and how that works?
Yeah. So in women with a uterus, we do need to prescribe a progesterone in conjunction with estradiol just to decrease the risk of uterine hyperplasia. So, estrogen causes the uterine lining to build up all these extra cells, which without a progesterone could increase your risk of uterine cancer. So, a progesterone comes in, causes the uterus to shed those extra cells, pretty much negating your risk of uterine cancer. So, that's, essentially why we would prescribe a progesterone.
Mm-hmm.
However, I have lots of women or I see lots of women that benefit from progesterone, even if they don't have a uterus, right? Progesterone is a lovely
Mm,
hormone that can really help with mood stability, especially if
mm,
one is experiencing really heightened moods, anxiety, feeling panicky, maybe irritable, or difficulty sleeping, right? If you feel like you
mm,
can't shut your brain off at night to fall asleep, it can
hmm.
really benefit sleep as well.
Wow.
Yeah.
So many things. And a lot of these things, I feel like when I'm talking with my girlfriends or in the last,
Mhm.
15, 20 years since
Yeah.
perimenopause for me,
Yeah. Yes.
talking with women, you don't correlate, you don't put it together that, okay, oh, this was a perimenopause thing, or this was a hormonal, like
Mhm.
frozen shoulder, a frozen hip, hair
Yeah.
loss, not sleeping through the night. All of
Yeah.
those things I didn't equate with, I just thought, oh, I'm just getting older. That's just a
Yeah.
part of getting older.
Or I'm in a stressful phase of life and I'm sure I'm just stressed
Yes.
because I've got kids and I'm working full time and I'm going to all these activities, running my kids around, managing a household, right? And I think
Yep.
that as women in general, we tend to put a lot on our shoulders anyways, right? Um,
For sure.
but yeah, so I think a lot of us are in that same boat where we just feel like I'm sure it's just stress. I just need to maybe do a face mask and have a glass of wine or something. But it's like,
Well,
no,
that won't hurt, but
you're right. It never hurts. But like those hormonal changes can begin as early as our mid to late 30s. And so it's very
yeah.
common for women to start noticing some symptoms based on hormonal fluctuations that early.
Mm-hmm. Yeah. I just am so grateful to learn all of these
Hmm.
things. And now that I'm grateful that we're all talking about it now, finally,
Yes.
that it's really getting more, it's the taboo is gone
Yes,
to
taboo
talk
is
about
gone.
it.
I think we're really starting to see the pendulum kind of shift back the other way,
Mm-hmm.
towards, look, hormones are good, they're beneficial, right? So,
Yeah. Yeah.
um, yeah, it's been a really fulfilling part of my career. I sometimes I just feel like the middleman of like, let's just give you back some of your hormones, right? I mean, these are things your body once produced. It's always kind of been my goal in doing so. Like, I want women to be able to self-schedule, right? They should be able to
Mhm.
just reach out and come see me if they want to, or come see a provider if they want to, because a lot of women have talked to their primary care docs and they're like, it's just part of life. You don't really need the hormones, right?
Yeah. They haven't
Um,
been trained.
and they haven't been trained. And so there's
Yeah.
no I get it, right? I didn't get the
Yeah.
training either. And so I think at the same time, though, women felt like, well, if my doc, like, I don't want my doc to be mad if I'm going to see someone to talk about hormones.
Oh,
I don't
gosh.
want
It's
them to
your
feel like I'm
body.
creeping around behind their backs or anything. But, and then it was also really important to be able to see women in a setting where they can bill insurance and then also go
Hmm.
get their hormones and have it be covered by insurance, right? Because these
Right.
hormones, bioidentical hormones, you don't have to go to some fancy compounding pharmacy for them. They're available at your local pharmacy, right? And go to
Hmm.
Walgreens and pick it up and use your insurance. So they should be affordable, they should be accessible. And to me, that was really important, for to provide to women.
Yeah, that's amazing. And you have had, I don't know if we mentioned this yet. You are now certified as a menopause
Mhm.
provider.
Yep. Yep.
Yeah. And
The Menopause Society, so they have a certification and they provide a lot of great information too for women in general, right? Not just those in the healthcare field. So the
hmm.
Menopause Society has a lot of great resources for women if you're interested in, looking up any more information on hormones or just menopause in itself.
Hmm. Yeah, I just feel like it's harder to find people providers who
Mhm.
are very knowledgeable as you are. I
Yeah.
mean, it's really there aren't enough of you.
Yeah. Well,
Love to
thank
clone
you.
you.
And I did just recently finish educating some primary care providers in our area, just kind of
Awesome.
providing the basics, right? Because again,
Yeah.
it was like we didn't get that. And I know that women now are talking about it. They're asking their doctors, right? Which is great. And I really I've always kind of felt like education is key, whether that is for my patients, for myself, or for my colleagues, right? And it's like you give someone the education and the information they need. I mean, they can be successful. And then, now we've got providers that are really wanting to provide great care to their patients. And so that
Mm-hmm.
was a lot of fun to be a part of. And I think a lot of providers were very grateful to have just good information. And hopefully we see that being offered more in just the primary care setting now.
Mm-hmm. Yeah, I think that's a great step forward. Can
Absolutely.
you talk a little bit more about the vaginal
Hmm.
estrogen? Because I feel like that's, it's something that's out there.
Hmm.
I've heard about it long ago, but
Yeah.
never used it because it kind of seemed gross to me.
Yeah, yeah, absolutely. It does. It seems a little weird. And, I think when we talk about vaginal estrogen, so we've got to talk about the genitourinary syndrome of menopause. Okay. So this is
Yep.
also a real syndrome, right? This that
Mm-hmm.
encompasses symptoms associated with the vagina with vaginal dryness, which can lead to pain with intercourse, bleeding with intercourse. The tissue of the vulva and the vagina becomes very tight and thin, can be very, very painful, right? I
Mm-hmm.
think this is something that's very slow to progress to where all of a sudden one day you're like, man, sex is really painful. That'll do a whole lot to a woman's libido too, right?
Oh,
Like
for
if all of a
sure.
sudden sex is painful, you're not desiring sex, right?
Mm-hmm.
And so that's not something that's just a natural part of aging, if you ask anyone. But not only does it impact like vaginal and vulvar health, um, but the urinary system. So
Mm-hmm.
the urethra, the bladder, in addition to the vaginal vault, very highly there's lots of estrogen receptors in the whole pelvis. And so when we are not producing enough estrogen anymore, we start to see changes not only with the tissue, but in urinary symptoms like urgency, frequency, burning with urination. I see a lot of women that feel like they have an infection, like a UTI quite
Mm.
often, and they don't. It's just the tissue changes in the bladder, maybe some inflammation, right, that can be causing
Mm-hmm.
these symptoms. So by replacing estrogen, to the pelvis. So with vaginal estrogen, either with a cream, a ring, or a suppository, inserted regularly, like 1 to 3 times a week, kind of depending on the severity of symptoms. It can
Mm-hmm.
really improve the urinary symptoms, the tissue integrity in general, helps
Mm-hmm.
the vaginal vault produce its own natural lubrication again. So it can really help with that pain with intercourse. Estradiol itself can decrease inflammation in the tissue in the bladder. It restores blood flow to the tissue. So I typically have women use the intravaginal cream, suppository, or ring, but then also applied externally some cream to like the clitoris, the labia minora, and just the whole vaginal opening to really restore blood flow to that area. Um, when we think about sexual function, something else that can decrease with age is the ability to orgasm, right? Or maybe it takes longer, or they're just not as intense. So if we can increase blood flow to the clitoris and the vulvar tissue, that can really improve orgasm quality and achieving
Mm-hmm.
orgasm. So lots of benefits to vaginal estrogen. And again, I think, when you realize what it can do, then you're like, okay, instead of it being like, oh, you've got recurrent UTIs, here, use this cream in your vagina 3 times a week and it'll fix you right up, right? And women are like, ew, I'm not doing that. Like, no,
Yeah.
why? How is a cream in my vagina going to fix my UTIs? But if we
Mm-hmm.
really kind of, again, educate the women on why it's working, what it's doing in the body, then they're like,
Mm-hmm.
makes sense, right? I'm
Maybe
going to
it's
use
worth it. Yeah.
this. Yeah. Yeah.
The thing that shocked me the most, I think, is I was a pretty regular, okay, 3:17 to 3:23. I don't know why, but
Yeah.
every time I look at the clock, I'd
Yeah.
have to get up to go to the bathroom. I
Yeah.
don't have to do that. I sleep through the night now.
I love hearing stories like that. I think that when I'm first talking to women about vaginal estrogen cream, and they probably leave my office and think this lady's crazy, like she's obsessed with this vaginal cream, right? And but then it's like they come back in a few months and they're like, "Oh my God, I haven't had an infection in 4 months. I can have penetrative intercourse with my husband, like I'm not
Mm-hmm.
dry anymore." And a lot of women
Mm-hmm.
are like, "I didn't even realize I was dry." Until you're not. So
Yeah.
it's, yeah, I mean, and then the urinary symptoms, that's the other thing. Sure, we can give women medications for urgency and having to get up at night a couple times, but
Mm-hmm.
then you're on a medication for, probably the rest of your life.
Mm.
Those
Yeah.
bladder medications come with side effects. Vaginal
Mm-hmm.
estradiol really doesn't, right? So,
Yeah.
I mean, very, very safe for women of all ages to use.
Plus, if you're taking something orally, that goes through
Mhm.
your kidney and liver,
Yeah.
right? I mean,
Yeah.
I need my liver for other things.
Yes, yes, we do. Yes, we do.
Yeah. 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 My husband and we were talking about all of this, and he said, "Tell your urologist I'm a big fan."
Happy to help.
Yeah.
Always happy
Yeah.
to be of service.
Yes, I'm a big fan too, by the way. So,
Yes. Well, thank you.
yes, absolutely. Talk a little bit about testosterone, if you would.
Yeah. So, one thing that most women don't know is that our ovaries produce more testosterone than estrogen, right? So,
Mm,
testosterone
wow.
is a very important hormone for women. It's just, again, one of those things that we were failed to be taught in health class.
Yeah.
So, we produce about a tenth of the testosterone that men do. But testosterone is still very important when it comes to sexual function, cognition, mood, muscle mass maintenance. So, lots of benefits can be had from testosterone replacement therapy. A lot of women may think, well, how do I know if I need that? Or, will I benefit from testosterone? So I always look at symptoms when we talk about prescribing testosterone in women, but I think it's important to note that our testosterone levels peak when we're in our 20s and 30s. And then that is one that doesn't fluctuate a whole lot, through perimenopause like our estrogen and progesterone do, but it kind of just slowly peters out, right? Until it's at
Mm-hmm.
a very low amount. Um, so and testosterone levels in women are going to vary, right? We don't know really what our testosterone level peaked at because we don't regularly check hormones in women
Right.
when we're unless there's like some fertility issues going on or other hormonal issues going on. But so testosterone can be very beneficial. We do have really good guidelines on how to prescribe testosterone in women, specifically for female sexual dysfunction or low libido. So we prescribe testosterone at a very low dose compared to men. It's usually about 5 milligrams a day. You can get that compounded. Um, there is not a female FDA approved testosterone product in the US
Mm-hmm.
yet. So, compounding pharmacy is a great way to go. We have some ways of prescribing male products, off label, clearly,
Mm-hmm.
but to get that testosterone replacement and to have it still be cost effective, right? But yeah,
Right.
I mean, I see a lot of women benefit significantly when it comes to libido, mood, energy levels,
Mm-hmm.
focus, motivation. So it can be really helpful whether you're a
Mm-hmm.
woman in your 30s, 40s, or even, a woman in your 70s.
Yeah. It's kind of shocking. I think a lot of it is, but and
Yeah.
and I don't know if we talked about this yet, but being your hormones, every like a man and a woman that we both
Mhm.
have
Mhm.
estrogen and
Yes.
testosterone. That I think is, growing up, you think estrogen is for girls
Hmm.
and testosterone
Yeah.
is for boys, but
Yeah.
it's not. That's not true, right? But
Yeah.
during our childbearing years, can
Yeah.
you talk a little bit about the levels? Like we have a higher level of estrogen, and then it just crashes in menopause,
Yes.
correct?
Yes. And so typically, I mean, again, we don't do a whole lot with like checking, our hormones throughout the
Mm-hmm.
month, but on average, during reproductive years, a woman's estrogen level is going to be at like anywhere from maybe 30 to 50. And then before your period, it's going to spike up anywhere to maybe 300, 500, seven
Wow.
hundred, right? And then come back down. Where
Mm-hmm.
progesterone kind of also has those peaks and valleys as well throughout the month, according
Okay.
to, other hormone responses in your body. Um,
Mm-hmm.
and so, again, when we're pregnant, then our estrogen levels can creep up to the thousands, right? Even ten
Wow.
thousands. So, very dominant hormone, while men, they have usually a pretty steady state of estrogen in their bloodstream, maybe around 30 to 40, throughout their lives, essentially.
Mm-hmm.
In perimenopause, we don't have that predictable flow or influx of hormones. It just is kind of all over the place as our
Mm-hmm.
body's trying to ovulate and kind of get every last egg out that it can, right? And then once we reach menopause, we're just essentially at zero, like zero
Wow.
progesterone, zero estrogen, and then our testosterone is slowly creeping out the door too. So
Okay.
then men, when, I talk to a lot of wives and it's like your husband probably has more estrogen than you do right now. So if we can at least match your level to his, I mean, that would be great, right? You'd probably be
Yeah.
feeling a whole lot better as well.
Mm-hmm. Yeah, that swing is just
Mhm.
mind-boggling, really.
Yeah.
And it
And I
explains a lot.
It does. And I think those fluctuations of the hormones in general are, really are what are causing the symptoms in women, whether it's physical or like the cognitive or mood changes.
Mm-hmm.
A lot of women are very sensitive to those hormone fluctuations and they can always tell, like, I'm going to be starting my period here in the next day or two. I
Mm-hmm.
can tell based on
Yep.
how I feel, right?
Why am I
And so
so pissed off? Yeah.
yeah,
4 days
yeah,
later.
yeah. And so I feel like when you're really sensitive in your reproductive years to those hormonal fluctuations, perimenopause can be quite rough.
Mm, preach.
Yeah.
Oh my gosh. I just feel like we've covered so much, but I know I'm not thinking to ask you everything. What other
Yeah.
things do you encounter in your practice or have you noticed
Yeah. I mean, I guess if we're speaking particularly around women's health, right?
for sure?
I have just found it very fulfilling to be one to ask kind of the hard, awkward, uncomfortable questions, right? And again, I think it's just because I want to know the answers to those questions. So when it
Mm-hmm.
comes to like sexual health, right? I think that I really like to provide a safe place when it comes to sexual function, sexual health. And so, libido is something that we discuss quite often. And I
Mm-hmm.
think as a urology provider, it fits really well with what I do, right? With kind of the field
Mm-hmm.
that I'm in. And there's been so much focus on men's sexual health in history.
Oh,
So
yeah.
to be able to provide good sexual health to women has been very fulfilling and I think very validating to women too, because a lot of women will come in and say, I just have no desire for sex anymore. And it's like, well, let's break this down a little further, right? Because desire is a very complex
Oh,
topic.
yeah.
And so a lot of times when we break it down, we can say, well, is sex painful, right? And they're like, yeah, I am so dry. It's very painful to have sex. Okay, well, then clearly you're not going to desire that, right? So if we can fix the
Mm-hmm.
physical aspects of that and improve the comfort and quality of intercourse for them, then they might desire it a little more, right?
Mm-hmm.
Or if it is truly just, I just don't think about it. And I would love to initiate sex with my husband. Like, I love him. I want to have sex with my partner, right? But just
Mm-hmm.
not thinking about it can be very um, devastating for women, right? It's like, I used to be a
Mm-hmm.
very sexual being. Like, what's wrong with me? And
Right.
truly, there's nothing wrong with you, right? And it is okay to want to desire sex, right? Like that is okay. And I think for women to realize
That's
that,
big.
yes,
That's
it
just a
is.
shift, because depending on how you grew up, but
Yeah.
to want to desire sex, that's a big
Yes,
shift for
it
a lot
is.
of us.
And it's one of those things too that I think as women we've always kind of it's never that like we can't have it because we can always receive penetration, right? But it's like we are more than just like this receptacle for
More
penetrative
than a vessel.
intercourse.
Yeah.
Yeah. And so I think it's important to discuss that with women and having a healthy libido if you want we can do that. There are a couple
Mm.
new medications on the market that have been out just recently within the last few years, targeted specifically at hypoactive sexual desire disorder. So for low libido in women, right?
I didn't even know
Um,
that's a thing.
yeah, yeah. And so new medications that are out there, I still love testosterone as first line treatment for libido just because of the other benefits that it can offer. But
Mm-hmm.
these other medications that exist, there's one, it's an oral pill. You would take it daily. It's called Addyi or the little pink pill. So there's a lot of talk about
Mm.
that lately. But it works in the serotonin receptors. It's a serotonin agonist antagonist, so actually works within the brain, right, to help with
Okay.
libido, with the mood. So that is a great option for women. And then there's also like an as needed injectable formulation, like a cyclic peptide medication, that we don't really know why it works to increase libido. They discovered that they were looking at this medication. It's a melanocortin receptor agonist, which when you think like melanin, you think of skin pigment, right? So they were
Yeah.
studying this agent when they were looking at like how the skin tans essentially, and found
Okay.
out that in the people that were using it had increased libido. So now
Really?
we have this other great treatment option for low libido for women. So
Wow.
yeah, I think it's important for women to know that you're not alone in that either. There's help,
Mm-hmm.
if you want want sex, if you want to think about it, that is
Uh-huh.
fine, right? And so there
Yeah,
are things to try.
that's
When we
okay.
think of like serotonin receptor inhibitors, right, or medications
Yeah.
for like depression,
Sleep, right?
anxiety,
Yeah.
sleep. So like
Mm-hmm.
antidepressants, they can cause low libido, right? And so there's a lot of
Okay.
SSRIs, SNRI medications like the Prozac, or
Mm.
not Wellbutrin, but like Effexor, like all these medications that work
Uh-huh.
with the serotonin receptors in the brain,
Uh-huh.
and they can cause low libido. So then this medication kind of comes in and causes the
Wow.
opposite effect. Yeah.
Okay.
Yeah.
Wow. Fascinating. And so all these the chemical imbalance that we could go
Mm-hmm.
through just because of the hormones is just
Yeah.
fascinating. And yeah, I'm so grateful that there are people out there studying it like you and talking about it and
Yeah. It's
making it
important for
okay.
sure.
Yeah. Yeah. The other thing I thought of when through this whole process was how important it is for elderly women to
Mm-hmm.
know about the vaginal cream, especially, but
Mm-hmm.
the hormone replacements, as we're aging.
Mm-hmm.
I remember when mom and dad were in the care center,
Yeah.
and a lot of the women in there had UTIs and
Mm-hmm.
were just miserable.
Yeah.
And it was just part of aging. I mean, that was just something that
Yeah.
they had to deal with. But that the vaginal cream is now helping that, right?
Yes, and it can. So, I mean, the vaginal estrogen alone can decrease a woman's risk of UTI by 60 to 80%. And it's so common in our elderly female population just
Mm-hmm.
because they've been without estrogen for decades,
Right.
right? And so
Right.
we see that quite often. Um, and I think that it's important to know. So, like, if your listeners have moms or aunts or family
Yeah.
members that are in a care facility, there are other options than the vaginal cream, right? I have a lot of
Okay.
elderly patients that maybe live at a facility and they don't want the nursing staff putting vaginal
Right.
cream,
I
So they do make, they have a vaginal estrogen ring. It's called the E string, and that can be placed by a healthcare provider. It stays
Mm-hmm.
in for 3 months, provides that
Oh,
local
nice.
estrogen therapy, and then when
Uh-huh.
they can go back to their doctor and have it removed and put back in. And so
Okay.
very easy. It's similar to like, I don't know if you remember like the NuvaRing birth control. There was like a little
Yeah.
silicone kind of ring. So it's very,
Mm-hmm.
very flexible, very easy to insert and remove, and can be a really good option so that then those elderly women aren't having to, have their nursing
Yeah. That
staff.
invasion. Yeah.
Yeah. And,
Ugh.
I think
Yeah.
there's like a generational divide there too of comfortability with even
Oh, yeah.
touching the vagina, right? So we
Right.
just we want them to be comfortable as well.
Even talking about it, I'm sure,
Yeah.
and yeah, all of it is that's a difficult conversation for a daughter to have with a mom,
It
probably.
is. Yeah, it really is. Yeah.
Mm-hmm. Wow.
It can be overwhelming, I think, too,
Yeah,
for
oh,
women to
for
take it all
sure.
in.
Uh-huh. Yeah, what are and I know you gave me a whole list of resources
Yeah.
to go to. Um, I'll include that list in my
Yeah.
show notes for
That's
people.
great. Yeah.
Yeah. Is there anything that anyone listening, what should they ask it when they go
Mhm.
to their primary care provider?
Mhm.
What would be a good way to start the conversation?
Yeah. Well, I think, being educated for one, and knowing, like that there are safe routes of estradiol for essentially anybody, and that it's not too early to start them. So if you're still having menstrual cycles, sometimes that's a big like, oh no, you don't need it yet, right? But if
Mm,
you are having symptoms and something just feels off, I think that's what I hear the most is that I can't put my finger on it. I
mm,
just don't feel like myself, right? Something is wrong. That should be a trigger to talk to your doctor about possibly starting some hormones. If you do share that list, there's a lot of great resources on there from urologists, OBGYNs, internal medicine doctors that they review all the data. And so you are going to get very good knowledge from those providers. But I think to say, to take in a paper, you can take in the Menopause Society's mission statement from
mm,
2022, and it says exactly what the hormones can be used for, and it talks about the safety and efficacy. So if you feel like you need fuel for your fire,
mm-hmm,
to start this conversation, take that in and say, I have read that
mm-hmm,
estradiol is safe and can help with this, and I would like to try some. I mean,
mm,
there's really very few side effects or risks to using a hormone that your body actually produces, compared to some other medications that you may be offered, right?
mm-hmm. Yeah,
So
absolutely.
and don't give up, right? Like you can always seek out someone else. I think that healthcare, it really does require a team of people on your side,
Yeah.
right? And
Yep.
so if you have your primary care doc and you love them and they're taking care of your immunizations and your annual physicals and getting you referred to places that you need to be, that is amazing. You need a good primary care provider in your corner, but like to seek out other specialties, to really help build your healthcare team to make you feel very well supported and healthy, that's very important. So
Mm-hmm.
never be afraid to seek out other specialties or providers.
Yeah, absolutely. And I look back to when I first started having symptoms, I couldn't
Mhm.
put my finger on anything, really.
Mhm.
I mean, because some of those things sneak up on you. You might have
Yeah.
you feel a little off, but
Yeah.
I'm just going through a phase, or I'm stressed out, or, something might be going on. For me, too, a lot of them, I would have some of these symptoms for a few months at a time, a few weeks at a
Mhm.
time, and they'd go away for a while, and then
Yeah.
something else would pop up, like the frozen shoulder. I mean,
Yeah.
it was so weird. I would have it for 7 or 8 months, and
Mhm.
poof, it's gone. I went to
Yeah.
physical therapy, didn't help it really, and then
Yeah.
it's just gone. Some of those things just I didn't equate those things with maybe it's hormones.
Yeah.
How it.
I think that's very common. And, what I hear a lot of women say is, I don't know if I have adult onset ADD. Am
Oh.
I developing dementia? Do I need a divorce and move out of the country? Like what is, do I have like insomnia all of a sudden? Like,
Uh-huh.
and I think that's why when you go to the doctor, it's like, oh, well, here we can, yeah, try physical
Here's
therapy.
Ambien and
Try,
here's
yeah,
this and
yes, here's an antidepressant. And it's like, but I'm not
yeah,
depressed, but I
right.
don't know. I just can't put my finger on it. And to me, that screams perimenopause, and it's like,
Exactly.
I mean, there was a study done recently where they looked at women aged 35 to 55,
Mm-hmm.
and just asked about the statement of I don't feel like myself, right? The not feeling
Mm,
like yourself is just it's like
yeah.
almost its own symptom. And like 60% of women reported that in that age category. Just like their
Wow.
symptoms aligned with this, I do not feel like myself.
Yep.
Um, and that I think that just speaks volumes. And I think again to
Hmm.
show that a lot of women are living through that exact same
Yeah.
thing.
Well, and for years, because it wasn't studied, I think a lot of women were told it's all in your head.
Mhm.
I
Yes.
distinctly remember my mom going through some perimenopausal issues, episodes, problems
Hmm.
back years ago. And she was told, oh, it's all in your head.
Yeah. And that's awful. I mean, because then women don't want to talk about their symptoms, right? Because
Right.
they feel like, oh, they're just going to think I'm crazy,
Something's wrong with me.
Yeah.
Yeah. Something's
I
wrong
think
with me, or nobody cares.
yeah, or they're not going to do anything anyways, so why should I bring it
Right.
up, right?
Yeah.
I think it's important to note too that like there are some women who coast through menopause without a lot of physical symptoms. They feel fine, right? Like,
Mm.
great, lucky them, that's amazing. But those women should still have the conversation about hormones because when we do look at estrogen being, approved to prevent osteoporosis, so not only does it prevent the loss of bone, but can promote bone rebuilding, right? So I think
Hmm.
that's really important too. You don't have to be struggling with these symptoms to still
Hmm.
benefit from estradiol. Even at a very low dose of estradiol, you can have that those good benefits to bone health. And then again, if started within that 10-year window, can be very protective of your cardiovascular health as well. So
Mm.
for women that don't have symptoms, you can still benefit.
Wow. How common is it to not have symptoms during menopause or during perimenopause?
I really don't know that exact statistic. I don't
I
know
know
that
one
number.
woman in my circle. One.
Yeah. Yeah. I know, and it's like this is not fair. And I've only come across a couple in my practice as well, and they have come
Hmm.
in just to discuss like, well, what are the benefits? Like I'm not having any of these symptoms. What are the benefits? And I think that's great because some women may feel like, well, shoot, if estrogen can do this and this and this, they're not going to prescribe it to me because I'm not symptomatic. And it's like that's not true. You can still reap the
Yeah.
benefits for bone health and heart health.
Yeah.
So,
Yeah. And that kind of shows if you have not encountered much of it, that I mean that's just a anecdotal
mhm.
reference, but
Yeah.
there are not many of us who have not had
They're
something.
correct. Yeah.
Yeah. Okay. Okay, can I switch gears on you?
Yes, please.
What's your favorite cocktail or glass of wine?
Ooh, okay. So I am a sucker for a good glass of Prosecco,
Oh,
honestly.
I love
Just,
that. Yes, I
yes,
love Prosecco too.
dry Prosecco.
Yes.
And I've loved that for years, right? And then my wine is more of like a seasonal thing. So I love like in the
Yeah.
fall, winter, I love a good like Cabernet Sauvignon. I love
Uh-huh.
a Pinot Noir. And then in
Mm-hmm.
the summer, Sauvignon Blanc, probably my
Yes.
fave. So,
Mm-hmm.
but Prosecco year round, love it.
Love it too. There's something about bubbles.
Yeah,
You can make a Tuesday a celebration. So,
absolutely. Absolutely.
yeah. Do you like spicy things?
I do.
Um, try, if you're up for it, try a sliced fresh jalapeno. Put a couple of rings in your Sauvignon Blanc next time you have a Sauvignon Blanc.
Um, I tried that once last year,
You
actually.
did?
We grow a small garden in our house and we had some
Yes.
jalapenos sitting on the counter and I just happened to
Uh-huh.
have a nice cold bottle of Savvy Bee in the fridge. And so I tried that and it was fantastic.
Isn't
So
it good?
yes,
Yeah.
very good. Yeah.
It's almost lethal in Prosecco, though. I tried that one time and it did not work.
The bubbles must do something to it, I would
They
imagine.
must, because it was
Yeah.
like, oh my God, I can't even get my nose up to it.
Yeah. Oh, that's funny. I won't try that then.
Okay, yeah, just word to the wise.
Yeah. Yeah,
Okay,
absolutely.
so what's a fun memory of sharing Prosecco or anything
Yeah.
with some girlfriends?
I just think that there is nothing better than opening a bottle of wine with a
Yeah.
girlfriend, whether it's out at a fancy restaurant, at a vineyard, or like at one of our houses in our comfy jammies and just talking and being
Yes.
present and laughing. And I mean, I think most women would agree that like time with your girlfriends is just it's healing, right?
Mm,
It is so
so
amazing.
much.
And yeah, I mean, honestly, I could be anywhere, sharing a bottle of
Yeah.
wine with a girlfriend, and it's my favorite. So,
Yeah. Me too. I think the older I get too, the more important it becomes to
yes.
spend time with girlfriends.
Absolutely. I've really tried to focus on kind of scheduling that in at least once a
Yeah.
month, you know. Um,
Yeah.
I think once your kids are a little bit older and they don't need you as much anymore, that was a really hard time for me in my life. And it was like, nope, I'm reconnecting with my girlfriends. And it really just
Mhm.
kind of brought me back to life. And it's like they
Mm.
get it, we
Yep.
understand each other, and you can laugh and you can cry and just never feel judged. And it's
Yeah.
girlfriends are the best.
It's awesome. And it's really important, I feel, to schedule that time because life gets in the way. It's just we
Yeah.
get busy. Other people take our other things are priority, and we
Yeah.
put ourselves last so often. So it's just
Yes.
important, to make that a scheduled time and
Hmm.
do it.
Yeah. It's, yeah, very important. It's not only do they fill your cup, emotionally, but they refill your wine glass, right?
Yes, they do.
They're always good at that. You can always count on your girlfriends for that.
For sure. For sure. I'm here for you.
Yeah.
Oh gosh. Is there anything else that you would love to share with my audience that I haven't
You
asked you
know,
about?
I don't know. I think we've covered quite a bit.
Yeah.
So if there's any questions, from anybody, you can always send them my way. I'm happy to
Okay.
help answer any questions, or help when it comes to if you've got people wanting to go to the doctor, and what information can I ask the doc, right? But again, that resource list that I gave you, a lot of
Mm-hmm.
the docs have lists like on their website that you can print out and
Mm,
take to your primary care. So they are all women's health advocates as well, which is why I love learning from them. So
yeah.
some good resources to share.
Awesome. If someone has questions and would like to reach out, how would you like them to get in contact with you?
Yeah. So they could email me with
Okay.
questions, right? So
Mm-hmm.
you have my email address if you can share
Mm-hmm.
that just on
Yep.
your show notes.
Sure.
But
Yep.
if you are interested in actually coming for like a consultation, right?
Mm-hmm.
My website, the which you could probably share that too, at
Uh-huh.
mercycare.org, you can actually self-schedule with myself and one of my colleagues. I've got a nurse practitioner that I work with that is also practicing menopause hormone therapy as well. So, yeah, if they want to actually have a sit down and have some designated time to discuss individual health needs and hormone needs, then they could get in touch with me that way.
Okay. Awesome. And you're in the Cedar Rapids area for those
Correct.
listeners that might not be
Yeah.
nearby. And
Yep.
if do you know of well, I think in your resources there's a link, but how would you recommend someone listening from Houston or, somewhere else?
Mhm.
How would they find a provider
Yeah.
like you?
So the Menopause Society website, you can actually search for a Menopause Society certified provider on their website. So,
Okay.
I would start there, and because they're all over the country, I would start there to find a provider.
Okay. Awesome. This has been so fun. Thank you so much.
Yes, it
Very
has been
helpful.
fun. Thank you for thinking of me and having me on today.
That's a wrap on this episode of Penny for Your Shots. If you loved today's conversation, don't let the inspiration stop here. Get my weekly insider updates straight to your inbox. It's where I spill behind the scenes goodies, exclusive tips, and all the fun stuff I don't always share on the podcast. Sign up now at pennyforyourshots.com/insider. I'll see you in your inbox next Thirsty Thursday. Cheers!